Now, another question that comes in, and I feel like it's kind of infused over the whole day, and that is, if you have a common EGFR mutation, can your cancer develop into or mutate to develop a different driver mutation like KRAS or MET or RET? And accordingly, should it be retested for new mutations on progression? Now, I would just highlight that the answer is yeah, there's certainly very relevant new mutations that can be identified and guide therapy. However, we're speaking to a very broad audience of people who are being treated maybe at academic centers, referral centers with access to clinical trials, and a lot of folks who are being treated in a broader community setting. And while it is absolutely, I think there's a strong consensus that it's really valuable, if you can, to know to repeat a biopsy and potentially find something relevant that could guide therapy. At this time, it's not a standard of care to do that we don't have a well-established approach that leads to an expectation of people having mutations, retested at rebiopsy. And as I alluded in some of the tail end of my talk, some of the acquired resistance work has shown that it may not matter as much as we would expect right now in terms of predicting whether some of these promising agents or combinations are going to have some utility for you. So helpful to move the field forward, not a standard of care at this time. Justin, I don't know if you have a different perspective.
Yeah, so to get at the specific question here, do some of the mutations change? I would say, when we're talking about EGFR, we're talking about ALK, these are what we refer to as founder mutations or founder occurrence, meaning that they are the earliest alteration in one of the earliest alterations in the tumor, and so that they are present in all of the cancer cells, and so that is generally not lost. When we talk about other things occurring, it's usually under the setting of a selective pressure. So if you give a targeted therapy, we know you can develop acquired additional alterations, so when we think, it's not that the cancer turns into KRAS or RET, it's that the EGFR mutation in the tumor has also acquired a RET fusion. So just to distinguish that. I would say for the amivantamab lazertinib data, I agree. There's not a profound difference, but I think there is some. It was 45% if you had EGFR MET driven. Actually went up to 90% if you looked at EGFR MET by immunohistochemistry. Granted, only 10 patients, within that subgroup. So I think it's too soon to say. We need to know more. And you're right. I tend to approach this as someone who is in a big academic institution, and where much of my standard of care is fused with research and all those things. And so part of my mission is to accelerate kind of in.
Right.
So,
and that's really the reason. I mean, not to say that, I don't mean to minimize it, but to say that someone isn't getting substandard care, to not get that out in the community. It's not, that's moving the field forward, but at this time, it's not something that we would consider wrong.